And for those people who are trickling in, they'll get caught up. Welcome to the Alliance of Nurses for Healthy Environments Practice Work Group meeting. Today is Tuesday, October 11th, and we are delighted to host this webinar entitled Scavenging Waste Anesthetic Gases for a Greener Future. My name is Lisa Hartmeyer, and I co-chair the Alliance of Nurses for Healthy Environments Practice Forum along with Liz Joseph. I will be moderating today's webinar. Before introducing the speakers, just a few comments on housekeeping. The format of this meeting will be a presentation followed by time for questions and answers. And please type your questions into the chat instead of the Q&A area. You can put them in at any time and we will do our best to address them at the end. Also, please keep yourself muted during the presentation. During the webinar, I will also provide a link to supplemental documents provided by the speakers today. And after the webinar, we will follow up with an email with a short post test if you're seeking CEUs, and this will be good for 1 hour of CEUs. We will also include the links to the follow-up materials provided by the speakers. Without further delay, I would like to introduce our speakers, Dr. Elizabeth Card and Connie Hardy-Tabbitt. Dr. Card is the past president of the American Society of Peri-Anesthesia Nurses and serves as the chair for the American Society of Peri-Anesthesia Nurses Action Coalition to Address Waste Anesthetic Gases. Connie Hardy-Tabbitt serves as the president of the American Society of Peri-Anesthesia Nurses. When you're ready, please take it away.
It didn't start where I needed it to. Hold on just a moment. Here we go.
No problem. It wouldn't be a webinar without some technical glitches.
All right. All right. Can you? Yes.
Looks great.
Excellent. So thank you for inviting us here today. ASPAN is thrilled to be here and share this information with you today. We are just delighted to discuss the current state, the recommendations that we have for improving the air quality and the health of the peri-anesthesia care environment. Raise your hand in the chat if you've ever had surgery or had a family member who's had surgery. Yeah, so there's quite a few in there. So let me ask you this, reflecting back on that experience, did you notice a pungent odor in the PACU or in the car ride home? Because if so, you were smelling waste anesthetic gases. And waste anesthetic gases, or WAGs, are as invisible as COVID. And while we cannot see them, we can definitely see and measure their impact on the health of the environment and the humans within it. Nurses are advocates for healthy work environments, as well as individuals we care for. Nurses witness the human consequences of policies, regulations, or lack thereof. A specialty nursing organization gives voice to many nurses advocating for issues that impact the organization's members and those they care for. In 2020, the American Society of Peri-Anesthesia Nurses, ASPAN, launched a multidisciplinary and multi-organizational action coalition to address waste anesthetic gases. And we're going to share with you some of our journey here today. So as previously introduced, I'm Elizabeth Card. I'm a past president of ASPAN. I'm here today with Connie Hardy-Tabbitt, our current ASPAN president. And we're concerned about peri-anesthesia nurses' unregulated, unrecognized exposure to waste anesthetic gases every single day. Our nursing organization represents an estimated 60,000 nurses across the United States. And while waste anesthetic gases are recognized in some areas of the hospital, they're in more places than just the operating rooms. So this is a timeline about what we know about waste anesthetic gases. And As you can see here, we've been on this journey for quite some time. The very first article that was published that showed a relationship between exposure to anesthetic gases in the occupational setting and poor health outcomes was published in 1967 by Vassman. And since then, there has been a huge plethora of publications to follow. In 1996, ASPAN, recognizing this trend of an exposure was causing a health problem, created their first position statement that called for healthier work environments and air quality within the PACU. In 1998, Sessler and Bagwell, and then again in 2002, Krasnichek et al. Both published their research studies. Dr. Krasnichek is here with us today, and in her study, she found not only were the waste anesthetic gases measurable in the air for the PACU, but they were also measurable in the blood as metabolites with the nurses that were taking care of these patients. They also measured exposure for patients who were in the PACU that did not receive these general anesthetic gases, showing that that's a contaminated environment where everyone was exposed to waste anesthetic gases. In 2013, OSHA released their anesthetic guideline for workplace exposure, naming the patient as the source of WAGs in the PACU. So everyone could easily wrap their head around why are anesthetic gases in the operating rooms, right? Well, they're using it. The anesthetic machines are there. And recognizing this hazard, OSHA also created regulations, policies with legal obligations for institutions to put into place some anesthetic waste removal to keep their people working in the operating room safe. And this was not happening outside of the PACU. So recognizing that the WAG in the PACU was there from our patients that come out of the OR with these lungs full of anesthetic gases. And once they come into the PACU, these anesthetic gases are not metabolized. They are exhaled out into an environment with no regulation or even recognition of this occupational hazard. In 2015, OSHA released a memorandum for regional administrators, state engineers, inspection guidelines for inpatient healthcare settings. In 2017, ASPAM President Bickerstaff contacted Dr. Gianardo requesting the ASA support for our position statement on air quality. In 2018, NIOSH, the National Institute for Occupational Safety and Health, launched a study in a community hospital. This is when they began it with our help from ASPAN to measure WAGs in the PACU. In 2020, the ASPAN Action Coalition to address anesthetic gases was launched. In 2021, ASPAN had a special event on WAG, which we'll share more with you later. In 2021, we also collaborated with the American Industrial Hygienists Association and created a white paper that's a really nice synthesis of the evidence. In 2022, ASPAN again collaborated with the American Industrial Hygienists Association in creation of a joint position statement that we'll share later. And here we are today with your organization, still on this journey. I'm going to hand it over to Connie.
Okay, we're going to do a little case study on pediatrics. This is your best friend daughter, Riley. She lives in Olmsted County, Minnesota with her family. She was born on December 30th, 2000 with a congenital hernia and a cleft lip and palate requiring 2 surgical procedures before the age of 2. Both procedures utilized the general anesthetics with the combination being combined exposure of 98 minutes. Riley has been diagnosed with ADHD and learning disabilities. Researchers have identified children with multiple exposures to general anesthesia before the age of 3 years old or combined exposures of at least 90 minutes as being more likely to develop ADHD, learning disabilities and cognitive abilities and academic achievements. There is a lot of trust in the care that is provided during a hospital stay. But there's that bigger picture and more to that surgical story that we really want to share with you. In a large study completed in the Olmsted County that followed a cohort of children from surgery to graduation from high school, found some remarkable correlations between anesthetic exposures and the development of learning disabilities, autism, and cognitive function. Surprise. For the 116 children who had multiple exposures to anesthetic gases, 457 singly exposed, 463 unexposed children analyzed multiple times, but not single exposures were associated with an increased frequency of both LD and ADHD. In this. So multiple exposures were associated with decreases in both cognitive ability, academic achievement, and single exposures were associated with modest decreases in reading, languages, achievement, but not cognitive ability. These are really astounding. When you come into the hospital and somebody's having surgery, you're not thinking of all these potential complications because they're not discussed. And next slide. Now this one, we have another case study, the post-operative cognitive decline case study. So this is your 70-year-old Uncle Chuck, who's had an MI and required coronary artery bypass, 3 grafts, urgently receiving general anesthetic, and a 2-day stay in a cardiovascular intensive care unit, during which he experiences a post-operative delirium where they get really confused. You visited him in the ICU. He was noticeably confused when you spoke with him, and then after discharge, he was unable to balance his own checkbook, requiring your cousin to be added onto his checking account. His cognitive status continues to decline, resulting in him relinquishing his driver's license, which was not easy, and ability to drive his beloved Ford truck. The 1-year anniversary of his surgery is next week. And last week, your uncle became lost walking this dog in his neighborhood, resulting in a family meeting and discussion of placement in a memory care unit. After the past year, continuous steady cognitive decline, post-operative decline after CABG or heart surgery and general anesthetic, where you get put to sleep, has been documented to continue on a negative trajectory for up to 1 year after anesthetic exposure. Versed, which is a medication that we give that has amnesic properties and to help them be more relaxed. Versed use has declined significantly in light of the contribution of the medication to use over 65 years experiencing post-operative cognitive decline. So overall, these are things that you're not expecting, but just by receiving general anesthesia, when we sign on the dotted line, these are some we're just giving you an exposure on anesthetic gases. I think this is back to you, Elizabeth.
Waste anesthetic gases. OSHA defines these as anesthetic gases that leak in small amounts from anesthetic breathing circuits, that would be in the operating room, or patients exhaling WAGs, which are 95% unmetabolized, which is how we receive WAG in the PACU. WAGs are inclusive of nitrous oxide and halogenated agents. OSHA estimates over 200,000 healthcare workers and veterinary workers are exposed to WAG annually, and that's just in the United States. In the operating rooms, WAG is reduced through engineering controls. That's where they have closed systems. So when these patients exhale these gases, they're removed from that room. Workplace practices, hazardous communication. So they are aware of their exposure and are communicating back what the exposures were in regular reports. They also do air quality surveillance programs. Few, if any, of these safety practices are in place in the PACUs, where the patients are the source of WAGs because they were thought not to exist previously. So WAGs are reduced in dental offices through engineering controls, workplace safety practices, hazardous communication, and surveillance programs that are not in place in the PACUs. And this is one of the things that the Aspen Action Coalition has been working very hard to raise visibility and understanding. Sorry, there's my dog. That these exist. Come here, Ozzy. And that the PACU nurses and the leaders that are associated with these areas of the hospital are primarily completely unaware of this exposure even taking place. So who is exposed to WAGs? So there's two buckets here that we've been talking about. There's the unintended exposures. These are the nurses that work in the PACUs. Also, the nurses that work in the cardiovascular intensive care units or in the trauma units or in the labor and delivery units, anywhere that they're receiving these patients directly from the OR. These nurses are unintended exposed to waste anesthetic gases. The other group to think about, and there are certain patients who have health risk factors. And because of these factors, the anesthesiologist will make a plan to not give these patients anesthetic gases. And they intentionally give these patients regional or total IV anesthetics. These patients, from Dr. Krisnicek and Dr. Slessler's research, we also know are exposed and do have some low level of metabolites in their body. So there's some cross-contamination that goes on in the PACU. And then there's the intended exposures, right? Our general anesthetic patients, which we talked about earlier, there can still be some negative consequences to their health related to these exposures.
So
I'm
while
going to
she's
hand it
getting,
over to Connie.
okay, yep. While she's getting that set up and ready to go. So how are people exposed? So we mentioned the PACU, which is AKA the recovery room, or after you have surgery. The nurses spend the majority of their time in the patient's breathing zone at the head of the bed. And for safety, this is an issue. They regularly request for asking them to take those deep breaths and cough and clear your lungs. That's part of our stirrup regimen to start waking them up and getting rid of those gases and getting the alveoli and their lungs start expanding them, because they've been laying flat the whole time. And now we want to sit them up and we want to get things moving. So it's part of to recover from the general anesthesia. This also places the nurses where they're at the head of the bed and they're exhaling these waste anesthesia gases, and that's unmetabolized. So here we want to share a film that demonstrates the waste anesthesia in the PACU, in the recovery room, as the patient is actively exhaling this. This is on a real person. And here we go.
Here you can see the face tent with the humidified air that's normally applied to the patient in the recovery room. The gases that you're visualizing are the waste anesthetic gases and not the humidified air. The special nitrous oxide lens on an infrared camera allows us to see this. When the face tent has been removed, you can see the gases once again coming out of the lungs when a patient's talking, and especially when they're coughing. Here you can see.
Okay, that still gives me the heebie-jeebies, because that, just like there's gases and you don't see them, we can actively smell them. And sometimes some nurses just don't feel well when they're at the head of the bed. So I'm going to do a case study for the PACU nurses. Let's talk about them. So you are a peri-anesthesia nurse, which is the pre-op or the PACU, the recovery room nurse. We use it generically, and that's what Elizabeth and I and Dina would be called. Peri-anesthesia nurse working in the post-anesthesia care unit is what PACU stands for. You work from 6 a.m. to 6:30 p.m. at night, and usually you do 3 12-hour shifts. So you work 3 days a week. You find the work fascinating and love waking your patients up, and the rewards, the various surgeries, educating patients on how to care for themselves, the delicate balance of controlling post-operative pain without sedating our patients. You were recently promoted to the day charge nurse position, providing direct supervision maintaining the flow of patients, and assist the PACU or the recovery room nurses during admission of your patients so they can go receive report or have a break. You begin to notice intense fatigue and tiring after working half of your shift. And by the end of the shift's end, reveals some difficulty in concentrating, but you dismiss this for the increased responsibilities at work. We've all experienced that, right? Fatigue. After 6 months in your new role as a routine annual visit, your PCP reveals increased creatinine and your BUN level. So your labs are a little out of whack. A surprising find because they've all been normal before. The next week, you attend a nursing conference and discover the documented connection between occupational exposure to waste anesthesia gases, or WAG, and a development of certain diseases, including kidney disease, the impact of WAG resulting in fatigue and a reduced concentration. And you're shocked. No one has ever discussed this exposure of waste anesthetic gases to PACU nurses at your facility, or your patients for that much, and schedule a meeting with your supervisor to share what you learned, because we like to take that information back, and then gain support to develop a plan to reduce the exposure. Environmental safety of our patients and our nurses are your concern, but protecting them will be an additional cost, as we know. Sadly, your unit is way over budget already, and this concern may not be a priority, and you dread the meeting coming up. How are you going to make a difference? We ask this question every day. How can we make a difference? And this is one way. Back to you, Elizabeth.
So this is a synthesis of the evidence that we pulled together with the Action Coalition to Address WAG. And the column on the left shows documented health implications, negative health implications related to exposure to high levels of waste anesthetic gases, even for a short period of time. So as the video showed, the patient that nurse was working with was fresh out of the operating room. And we spend the first 30 minutes with our patients at the head of the bed, right there within their breathing zone, as you saw in that video. And we have to do that for safety, because these patients are not completely conscious. They may get nauseated and asphyxiate on their nausea. There may be bleeding, and we have to be able to talk to them and keep them awake and keep them safe. So unfortunately, that is a very high exposure for a very short time. And these are some of the things that have been recognized that go with that. The column on the right shows exposure to anesthetic gases, and these are small amounts over a longer period of time. And the shocking thing about this, when you read on this, is that the miscarriages and the congenital anomalies and the low birth weights also happen in the spouse of the exposed person. So if it's a male anesthesiologist, his wife could experience these negative health effects because she also is exposed, which was pretty shocking. So this is some findings that we spoke about. The National Institute of Occupational Safety and Health, NIOSH, had started a research study in 2018, and any of you who have been involved in research know it's a long journey to complete a study, especially a study on waste anesthetic gases. These particular studies are exceptionally challenging to complete and are very expensive. So NIOSH completed the study at 3 different hospitals, testing some scavenging systems and the ambient air. And they recently published their findings in March of 2022, and they shared this with us, and were part of our special event. What's so interesting that we found is that the concentration first of the area samples that they contain were not in the workers' breathing zones, where we were showing you before, that is obviously the higher level. These were in ambient air areas throughout the PACU. But they found that the WAG concentration exceeded the NIOSH recommended exposure limits for halogenated agents and as well as nitrous oxide. So we know from this report, this is just the most recent piece of data, that WAG is there, it's present in the PACU, and it's exceeding what is recognized as safe levels. Additionally, they found that all of the PACUs, there were 3 different ones that they did this testing in, experienced at least 1 hour above these NIOSH recommended exposure limits. And this also indicates that just our current room dilution ventilation. So when you talk about room dilution ventilation, that's how many times the HVAC system turns the air over in the room and how many fresh air exchanges are coming into the room. So in the operating rooms, because they recognize these anesthetic gases are there, they have multiple fresh air exchanges throughout the hour. The PACU is no different than the rest of the hospital. So we're not having as much ventilation, but even then, what we do have is not enough to really decrease the WAGs to a safe level. And so it's insufficient. Effective source control is a proven way to minimize WAG exposure and to reduce the release of WAGs into the PACU environment. So the PACU patients are the source of the WAGs within the PACU. And if we can control and scavenge what they are exhaling, we can then also reduce the amount of waste anesthetic gases that are in the ambient air within the PACU that everyone is being exposed to. This was by the CDC. When you talk about engineering controls, I'm a nurse and working with the Industrial Hygienists Association. This was the first time I had seen this hierarchy, and I really like it because it really speaks to me, because most of my nursing career, we're down there in PPE, which is the least effective hierarchy of control of workplace hazard, but it's what we have. It's what we have. And then you can see administrative controls. You would change the way that people work, would be the next higher level. Higher than that would be to isolate people from the hazard with engineering controls. The next level up is substitution. Can we replace the hazard? Is there something safer we could use? I know there has been with the EPA a number of things that all of us have seen that the farmers used that have gone away because of the way that it affected living species. So they replaced the hazard within their regular work. And then the elimination is the physical removal of the hazard, which is the highest, most effective level of control. So when we talk about how can we control for waste anesthetic gases and how can we put in some source control, this possible solution here would be to remove the waste anesthetic gases where it's not in the ambient air. If there was a scavenging system, then we could not only remove it from the ambient air in the PACU, but possibly distill it and pull it out of the environment. So I'm going to hand this over to Connie.
Okay. And currently for the majority of nurses, we don't have this. We don't have an elimination process. We just keep inhaling it every day when we're there. So here's a quick demonstration. We have our second video, a demonstration of how we could apply source control. And it's very short, but effective.
That now can be used in the recovery room to give a patient oxygen that they need for their recovery, and at the same time capture these anesthetic gases that are being exhaled.
So I guess it's also important to point out there are several market available scavenging masks that are approved by the FDA that can be purchased that do this demonstration. We are not endorsing any of them, but we are asking for any of them. We would love to have any of them in the PACUs to remove this hazard from the nurses.
And I think something else we forgot to mention was
That
you don't
now
have a
can-
conflict of interest either. Something that we forgot to mention earlier, but we are not advocating one or the other. Our biggest issue is we have a problem and how can we solve it together?
Absolutely. Good point. So I was really shocked when I learned this. So you've heard us talk about how in the operating room, they safely contain these gases so people are not exposed. And what ends up happening, where do they go after they get them out of the operating room? Well, while there are some distillation devices that can reclaim these waste anesthetic gases, they are in very limited use because there's not any type of regulation with legal obligation for hospitals to use them. So the WAGs right now are exhausted out the roof of the hospital into the environment, into the atmosphere. And when you look at the impact of this on the macro environment, now previous to this, we've been talking about the micro environment, right? We've been talking about in the hospital, in the PACU, that it goes bigger than that. So when you look at the atmospheric lifetime of nitrous oxide, it's 114 years, which is just staggering. And importantly, isoflurane, which is listed there also, it's a halogenated agent. It carries a chlorine atom that consequently induces ozone destruction. Hence, it should be discouraged in favor of sevoflurane, which also, although it has a little bit less atmospheric lifetime, at least it's not destroying the ozone layer. Worldwide, total estimated equivalent release of CO2 by hydrofluorocarbonated anesthetic agents, which are those last three listed there, was approximately 3 million metric tons, with desflurane accounting for 2.5 million of these. This demonstrates the impact of desflurane use in clinical practice in a well-designated report by McNeil et al., in which huge tenfold disparities in greenhouse gas emissions between hospitals could largely be accounted to the use of desflurane in comparison with less harmful agents. So there's several different aspects we need to think about when we talk about the health impacts and the implication of waste anesthetic gases. So the research and the videos we've been talking about and to this point have really shown that WAGs can be captured at the source in the PACU, reducing nurses and other patients' exposure. WAGs can also be reclaimed instead of being exhausted into the atmosphere. Further research from Purdue University has shown the scavenging systems that capture the exhaled pathogens as well as the waste anesthetic gases. So this is a picture of the bioluminescent picture they took of the tubing. The one on the left is before they used it with a patient. It was a mannequin, and they were using bacteria the same size and viruses the same size as COVID. And they were using it with a scavenging system. And what they found at the end of their experiment, not only were they scavenging the waste anesthetic gases, they were also removing pathogens. So the bacteria and the viruses they were using for the study, they could use this bioluminescent light on and they would light up. And you can see by the tubing, it's full. And that reduced the exposure of anyone that would be around that person down to 98%. So now your PPE, which is at the very bottom of that list, is much more effective because you've removed 98% of their exhaled pathogens. So this was the special event that ASPAN hosted in August of 2021. We pulled together a fabulous panel of speakers and experts from around the country. We had some representatives from the American Industrial Hygienist Association. And for those of you who are not familiar with that group, they are the ones that help us use engineering controls to make our workplaces much more safer. So one of the things they led the charge on to have fixed was removal of mold from sheetrock. They recognize that health hazard and help create some standards and some way that we deal with this. So this was the group that ASPAN's Action Coalition has partnered with. And Dr. Jim McLaughlin was there to talk about WAG research along with Bruce Applegate from Purdue. Then we had Alberto Garcia from NIOSH, who released the NIOSH report we were looking at earlier. He shared his results with us and answered questions. And then we had a Q&A, question and answer, and all of the nursing organizations, we've talked to 8 that were interested in supporting this work, were able to submit questions to these panelists. And we had people from NIOSH, from OSHA, from the American Industrial Hygienists Association, and then we had 2 nurse leaders that were in a PACU that had before and after data when they implemented their scavenging systems to remove the waste anesthetic gases. And I know Dr. Krisnicek that's on this call is working with Jessica right now and writing up her findings, but they found a reduction in the nurses' ill days and their call out. And so it's unbelievable how far reaching this can be with just removing these waste anesthetic gases. This event was recorded and we have it posted on the ASPAN website. You can go there. You don't need a password to be able to access it. I've put the link down there. You are all welcome to go and watch the whole thing. You might want to have some popcorn with you. It's 4 hours, so it's a little lengthy. ASPAN has done in increasing the visibility and the education is we really needed a nice way to share all of the synthesis of the evidence and the recommendations to help create a healthier work environment. And so this white paper was created with the American Industrial Hygienists Association as well as ASPAN. And this white paper is a beautiful synthesis of all of the evidence that we have. And it's available on the website as well. If you go to that link I gave you earlier, it's on our website. It's also on the American Industrial Hygienists Association. You can download it, you can print it, you can email it. We encourage you to share this with your hospitals, with your organizations, with your colleagues, to get people to talk about waste anesthetic gases and what can we do to really ensure the health and the safety of our peri-anesthesia patients and our peri-anesthesia nurses. Then ASPAN partnered with the American Industrial Hygienists Association, and we developed a position statement on waste anesthetic gases. And this was approved by both organizations and our representative assembly in the last couple of months. And we are seeking organizations' endorsement of this position statement. This is something that we did share, and you will receive a copy of as well. But it's a smaller, it's the executive summary of the white paper, and it shares the evidence out there as well as making recommendations for what can we do to improve the safety and the environment, both within the PACU and outside of the hospital. And we were very honored this past June. Your organization invited ASPAN to co-present with AORN with Admiral Levine. And Admiral Levine is the Secretary for Health and Human Services that answers directly to the general surgeon. So we were very, very honored and excited to share our concerns about waste anesthetic gases. He was very interested, asked some great questions. Our key takeaways here today for the Alliance of Nurses for Healthy Environments. Healthcare providers continue to be exposed to WAG and pathogens in the PACU every single day. Additional concerns for pathogen controls, such as SARS-CoV-2 and that causes COVID-19 are a constant threat for our nurses. You saw how close we are to the head of the bed. And as Connie said, we're telling them, take a deep breath, give me a cough, let's move around. So they're exposed a lot. And when they talk about aerosolizing procedures, that is a cough. You do aerosolize when you cough. Source control devices have shown that WAGs and pathogens can be captured at statistically significant levels. And PACU nurses have been systematically working to improve their work environment by seeking help and expertise from Purdue University, OSHA, NIOSH, the American Industrial Hygienists Association, as well as your organization, to control WAGs and pathogens to improve the health of our work environment. So what can we do as individual nurses and as healthcare professionals? Share this evidence and the ASPAN resources that we brought here today with your hospital administrators and your leaders and anyone else that would like to be aware and learn more about this. There are market available source control that can be put on patients in the PACUs and in labor and delivery and in ICUs or wherever else these patients are to control WAGs and pathogens. And the source control are more effective than PPE. The N95 surgical masks are not going to prevent WAG exposure. It still passes through those masks. We do know that the WAG exposure for the PACU nurses are above the NIOSH recommended exposure limits as reported by that NIOSH report on their research study that we shared earlier. And because the WAGs are above the REL for NIOSH, OSHA can cite hospitals under the general duty clause, which is 5A1, for not providing a safe and healthy work environment when there are cost-effective market available controls available. And then hospitals that are exposed to possible litigation from nurses who have had adverse health effects from this exposure. So WAG and pathogen exposures are there in the microenvironment among healthcare workers in the PACU and other clinical units. Source control shows us that we can capture these WAGs and pathogens at significant levels. And hospitals are not implementing these protective systems because there's not a legal obligation from OSHA or from NIOSH that would really have them put forth these dollars and make this an important priority. And that is what we need your organization support for, your voices for, to help move this forward. There's no government enforcement requiring the use of source control, and these engineering controls are available, as well as the reclamation distillation devices, so it doesn't go out into the environment. So a brief concern, WAG and pathogen, oh, I apologize, that's an old slide. So how can nurses collaborate? We can request hospitals to implement changes that can improve the health and well-being of nurses, share the ASPAN position statement in the white paper, encourage NIOSH as an organization, reach out to them to recommend to OSHA to create regulations with legal obligation to implement WAG scavenging systems and devices. And there's if you are interested in learning more about these, there's 2 links there to 2 different source control scavenging masks that are available. The PACU nurses need your help. We're not going to really be able to move the needle on this one alone. It's going to take many voices. And we are engaged, invested in collaborating with all nurses. So together we can address this environmental hazard. There is my email address, and we're going to open it up for questions.
Wow, thank you so much for such an excellent presentation. Please feel free to type any questions you may have in the chat for any of our attendees. Let's see, it looks like maybe we have one hand raised. Yeah, just feel free to type any messages or any questions you have in the chat. I know this is such a big issue. Not only do waste anesthetic gases contribute to climate change issues, I was floored to know that nitrous oxide is in the environment for 114 years on average, and some of the others many, many years. But the health impacts on the individuals, the nurses, the family members, and the patients is striking as well. I see lots of opportunities for additional research here. This is more of a comment than a question, but I guess I can turn it into a question as well. But it's a difficult thing to study, twofold, because waste anesthetic gases are not necessarily easy to see, but for example, I believe you could see like isoflurane in nurses' urine. So you could test a nurse's urine at the start of their shift, 2 hours in, 6 hours in, 8 hours in, and see if you're getting that metabolites present in the nurses, and what is the accumulation over time. But the second difficulty there is then how does that translate into a health impact? What, it's difficult to know if these waste anesthetic gases exposures then translate into miscarriages 2 years later on. It's very difficult to prove that. So we have a lot of work cut out for ourselves to continue to do this research to understand the health impacts as well as create the policy. But as many of our nurses understand the precautionary principles, that we don't necessarily have to wait to have all this information before we take action. And so I appreciate that you have all put in the time to create the white paper and the statement so that we can try to capture these gases and make the workplace safer. Wasn't it just recently we had the World Health Organization in 2020 say that was 2020, the year of the nurse, right? And what a few years has it been for nurses, exposures to COVID and all the environmental health exposures. So if there's any attendees on this call that want to roll up their sleeves and get to work, there's lots to do. If you have any follow-up comments to that, please go ahead while I take a look at this Q&A question from Marilyn Gerber.
I would like to invite Dina Krisnicek to discuss her research findings where they did measure metabolites in the nurses' systems from the exposure to waste anesthetic gases. I think she's on the call here.
Maybe Sarah, you can let her join and discuss that as well.
And this was a year of the nurse twice, actually. 2021, we were robbed. And then 2021, they tried again.
Yeah.
Yeah, Sarah is letting the doctor in. It just amazes me that between the smoke from the cautery and the anesthetic gases, we have a time bomb here at hand.
Yes.
I'm surprised that OSHA, has not had more regulations put on these items. And like Lisa mentioned, and you mentioned as well, Liz, that nurses and the staff in general, in the OR techs, rest of the staff are not, aware of the consequences of what they've been putting through. And just having some discussions with our OR nurses and trying to bring about staff awareness, there's a little bit of pushback, I find.
Yes.
And I don't know if you had experienced that in some of the hospitals that you that you have addressed, or how do we overcome that pushbacks? It could be from administration, leadership, and so forth. So this is what we have to deal with. But I always say the strength comes from the grassroots. So we as one unit fight for, put this out there and take a strong hold, then the leadership will listen. Then administration will listen, or the anesthesiologist who's giving us a pushback. So I was just wondering if you had any experiences with this type of situations.
I will say in the past 18 months to 2 years, ASA has been releasing statements about how they need to reduce the amount of anesthetic gases they are using. The AANA, which is the CRNAs, are also talking the same language. So I think there is a very strong recognition of what these gases are doing, both to the intended as well as the unintended exposures that are happening out there, as well as the last paper I wrote about the greenhouse gas effects of anesthetic gases was written by some ASA members. So they are very aware. I think it's gonna have to come from the bottom up, like you were saying, as well as the top down. We're going to have OSHA and NEOSH, hook their arms with our nursing organizations to say this is a problem and there is a solution. I think Dr. Krasnichek is ready to talk about her study and the measurements she had of nurses with the metabolites from WAG.
Hi, good evening. I'm sure you can hear me. Thank you for allowing me to share my story. Our research was done at the Johns Hopkins Hospital in Baltimore, Maryland, and I have to give them a lot of credit because they were supportive all the way for us to do this. We had two phases of the study. First phase was looking at the different levels of waste anesthetic gas exposure from the 90 centimeter circumferences around the facial area of the patient, the foot part of the bed where nurses do their charting, and the nurses station. Obviously, the engineers think that the nurses station is where the nurses are working, and beknown to them, nurses were not at the nurses station. They're always at the head part. So obviously, when we look at the prevalence of the waste anesthetic gas, both hallucinated agents and nitrous oxide, it was present and was significant. I mean, really significant with the amount of level. The second phase of the study, and we were very fortunate, the School of Medicine scientist called me and said, I'd like to do a study with you in the PACU. And, when somebody knocks at your door, you just say yes, whatever they want. So what we did is we did a study on a Friday and a Monday. Those were the days that we worked 8 hours a day. Okay. So we look at the Friday because we wanted to see the cumulative effects of the halogenated agents as well as nitrous oxide. And Saturday and Monday, we wanted to know if it had cleared before they came back for their next week assignment. So what we've really actually done is he had examined the exhaled breaths of the nurses before and after their work. And of course, before their work, on Friday, there was some residue. And of course, he's looking at television screen and he's looking at the specs. To me, they're all dust, but he could tell all kinds of halogenated agents they were breathing out. So there was a significant difference before and after their work. Interestingly, on Monday, when they came back to work, we thought that when they were off, they started 0 in their lungs with all those metabolites. And it showed that on Monday, none of the nurses started on 0. They still have some metabolites in their lungs. And for the nurses that came on call or recalled over the weekend for emergency cases, they had a higher level coming on Monday. So as you see, as Elizabeth had said, that can be transferred to your husband, to your kids, when you kiss them, when you hug them, because as you exhale, you're still exhaling some of those metabolites. So unfortunately, we wanted to do the third study. We wanted to test the cognitive abilities of the nurses. Unfortunately, the scientists left, so we were not able to test the cognitive functions of the nurses. But it was so remarkable, and it made some changes. So when we reconstructed the PACU, we made some engineering control, and it's not still sufficient, but they've made significant changes in the structure of the PACU. Thank you.
Thank you, Dr. Krasnichek. Dr. Krasnichek, we have a question. I don't know if there's going to be an exact answer for it, but Jill Aquino asks, after a family member has surgery, how long is the family member's caretaker exposed to the WAGs? It's a great question. And tell me what you think.
Well, as I mentioned to you, the nurse that was exposed Friday, she still have it on Monday. So I don't know the length of time of that. You have evidence of that, Elizabeth? But that's the evidence clearly that we've seen among the nurses.
Yeah. Yeah, I don't know that anyone has followed them all the way down to there's none. We do know from the research that's been done is the highest amount of concentrations that the nurses are exposed to is the first 30 minutes when the patients are in the PACU, which is also the most critical. And that's when we're right there in their breathing zone.
So when we did the study, your maximum limit of nitrous oxide is 50 parts per million. We had as high as about 800 parts per million with the nitrous oxide. The halogenated agent is 25 parts per million, and we had as high as about the hundreds. So the really concentration is upon admission. And when we put the face mask, it seems like it's a false assurance that you are protecting. But after an hour, as you win the oxygen from the patient, you pick again with exposure.
And
I will
I believe, oh, go ahead.
I was just going to jump in that a lot of times as a nurse, we allow family members to come in and visit the first, especially if it's a child, because they're comforted by a child or somebody, a combative autistic child or adult. So those family members didn't sign on the dotted line to say that they were also going to be consuming this. And these are medications that we expect our patients to have a ride home with. And these are nurses are at the head of the bed having the same exposure, but we're driving home and we're operating at the highest scope of our practice.
It's true. And there has been one research study that was published that said you heard Dr. Krasnichek talk about the exposure limit to nitrous oxide should be less than 50. And then if it's combined with other halogenated agents, which a lot of times they'll combine those gases, it should be even less. When you can smell it, when you can detect that pungent smell, it's already above that by 100%. And you can smell it a lot in the PACU.
Absolutely. Marilyn Gerber has a couple other comments here in the Q&A suggesting some other opportunities for collaboration, asking about CCRN National Association to join and other ideas. So I'll let her follow up with you about that in the future. I have a question. I was wondering if your position paper, and I've read it, but I have to go back and read it because there's a lot of information in there, makes a recommendation about not utilizing nitrous oxide as a carrier gas at all, or is that a difficult recommendation to make in the setting of the anesthetic gases being a choice of the anesthetic team as well?
That's a great question. And the American Society of Anesthesiologists, as well as the AANA, the CRNA organization, realize the danger of these, and they are both publishing and putting forth recommendations to reduce use of those gases. So I feel like we're all lining up together to work on the same reduction in exposure.
Absolutely. I find it fascinating at the research that I've been doing over the last few years called the Women Workers Biomonitoring Collaborative is looking at exposures to nurses' blood and urine samples compared to office workers for exposures to medications and disinfectants. And it's using a non-targeted approach to see what's there. And one of the PACU nurses that I work with is the co-PI of the study. But the challenge that we're running into is that it's certainly difficult to study something that maybe fleeting or difficult to see, but nonetheless very, very impactful on both individual and the public health. So hats off to all of your amazing work on this in both the research area and the policy area. And I'm excited for future collaboration with Annie and individual nurses around this issue. Does anyone else have any other additional closing statements? Otherwise, we'll wrap it up and make these documents available to our participants after the webinar today. Sounds good. Thank you again for being present. I'm sorry I didn't get to the last couple of questions from Marilyn, but I think there's a lot. If you can read that white paper and the position statement, I think that will be our homework moving forward. And again, thank you so much to all our speakers for the work you're doing and your presentation today. Thank you again. Take care.
Thank you for inviting us.
Thank
Yeah.
you.
Bye-bye.
Appreciate the time.
Thank
Just a
you.
reminder, make sure everybody fills out the evaluations to get their 1 hour CE. It's
Thank
posted
you.
on the chat. Thank you, Dr.
Thank you.
Thank you.
Thank you, Elizabeth.
Thank
Thank you,
you.
Connie. Thank you, Lisa. Thank you, Dr. K.
Bye.